Okay, good afternoon, everyone. My name is Professor Gustavo Duque. I'm a geriatrician, chair of medicine, and director of the Australian Institute for Musculoskeletal Science at the University of Melbourne in Australia, where, by the way, is 4 a.m. So it's my pleasure to welcome everyone to our Frailty seminar series on behalf of the organizing committee. And before introducing the speaker that we have for our session today, I would like to make a few housekeeping announcements. The first one is we are going to, or you can submit your questions during this presentation using the QA function in Zoom. We are going to have also at the end of the session, we're going to distribute an evaluation questionnaire, so you can please take some time to answer those questions and bring us some feedback. We are very interested on your feedback and suggestions about these seminars. And just a friendly reminder and mark in your calendars about our next seminar, which will be by Melissa Andrew from Dalhousie University on December 8th. So with this, I would like to introduce our speaker for today, and it's my real pleasure to introduce my former trainee, who has grown a lot since I left Canada, but I have been following his career with great interest. Dr. Jonathan Afilalo is a cardiologist and researcher at the Duque Hospital in Montreal and a tenured associate professor at McGill University. He holds a graduate degree in epidemiology from McGill University and level 3 training in advanced cardiac imaging from Harvard University. His research program is focused on the assessment and treatment of frailty to improve health-related outcomes and successful aging in older adults with cardiovascular disease. He led the first and largest studies on gait speed in cardiac surgery and subsequently led the multinational frailty AVR study. He's currently conducting the PERFORM TAVR trial on home-based exercise and nutrition in frail older adults undergoing transcatheter aortic valve replacement. These contributions were recognized by the Royal College Gold Medal for Research, Canadian Cardiovascular Society Young Investigator Award Second Prize, and the American College of Cardiology Section Merit Award. John and his team have created digital platforms, including Frailty tool, which I invite everyone to check and try, and open source software, CoreSlicer.com, to promote knowledge translation in this sphere. John is founding director of Canada's first fellowship program in geriatric cardiology, and he is the co-director of the Jewish General Hospital Fellowship Program in integrated cardiac imaging, and he has contributed to international guidelines in the fields of echocardiography and cardiovascular MRI. So John, it's very nice to see you again, and we are looking forward to listen to your presentation.
Thank you very much, Gustavo, for that warm introduction. And in addition to thanking you for waking up at 4 a.m. to attend this talk, I'll also thank you for being my foremost mentor in the field of geriatrics. I met Gustavo a long time ago during my training rotation in geriatrics. With him, I was introduced to the biology of frailty, here showing a slide on lamin expression that we did together in his lab. And I was also introduced to gait speed as a practical measure of frailty at the bedside, and that really was a springboard for my research career in this field. It was the focus of my thesis study in 2010 on gait speed. It kind of snowballed from there, gaining a lot of traction in the cardiovascular world as far as finding objective ways to measure frailty. This was one piece in the Wall Street Journal about that. And finally, when I came back from fellowship in 2012, it really was again, the focus and raison d'etre of my research program starting with the Frailty AVR study across 3 countries. So thank you, Gustavo, for all of your wisdom and mentorship. I'll start with a case on 3 gentlemen that I took care of during 1 week in the cardiac unit. The 3 gentlemen are evidently older adults with ages 90, 80, and 94. And all 3 of them were admitted for decompensated heart failure in the context of severe aortic stenosis. The 3 gentlemen had variable amounts of comorbid conditions. The 2 gentlemen on the left of your screen had similar BMIs of 23, whereas the gentleman on the right was obese with a BMI of 33. And when we plugged all of their comorbidities and cardiac parameters into the Society of Thoracic Surgeons predicted risk of mortality calculator, we observed that their risk of mortality, should they undergo a surgical replacement of the aortic valve, was anywhere from 6 to 7.1%. So quite close in terms of these 3 gentlemen. If we take chronological age for 1 second, we've looked hard at this and tried to identify, is there a cutoff, not necessarily to define a frail older adult, but at least to help us know at what age we should start to screen older adults for frailty. And these are violin plots from older adults who either survived or did not survive their cardiac surgery, 3 different kinds of cardiac surgery. And we can see in the bottom row of the violin plots, the patients who did not survive were on average older, but there is substantial overlap here. And our best guess at a cutoff was anywhere in the 70 to 75 range, after which point the risk of mortality was more elevated, but clearly no magic number here to know when someone is going to be frail based on their chronological age. And moreover, even in the extreme of chronological age, so this is in patients 90 years of age or above, when they undergo contemporary cardiac procedures like transcatheter aortic valve replacement, their risk of short-term mortality is very low. So here, 5.5% in a meta-analysis that we did. So it's got to be more than chronological age. I think we all know that on this Zoom. So we have the tip of the iceberg is the items we've discussed, including chronological age, cardiac disease, and comorbidities. But we again know that what gets patients into trouble more often than not is not the tip of the iceberg, but rather what's underneath the surface. Sarcopenia, immobility, malnutrition, cognitive and sensory issues, fatigue, mood issues, social isolation, and more. And this has been proven time and time again in cardiac and also non-cardiac fields, where here we looked at transcatheter aortic valve replacements gone wrong. And gone wrong basically means that the patient at 6 months is either deceased or reporting a very poor quality of life, despite a technically successful procedure. Of note, the incidence of this poor outcome is anywhere ranging from 30 to 40%, depending on where you read. So the valve goes in perfectly, but 1 out of 3 patients 6 to 12 months later is still reporting poor quality of life or not alive. And it turns out that, as seen in this study and others, frailty seems to be a big determinant of this phenomenon of poor outcomes after successful cardiac procedures. It's also a big determinant of not sending a patient for a procedure. Here, a student of mine, Julia Rodiguero, looked at patients who did not undergo TAVR despite being referred to a TAVR clinic for evaluation. And the second most common reason elicited from the clinician was that the patient was too frail to undergo the procedure. And when that was the case, as you can see in the orange line, the mortality after that point was quite elevated, higher than if it was not done for other reasons. So frailty is a common reason for not doing a procedure, and it's also a common reason for having a bad outcome, whether or not you undergo that procedure. So of course, we have to talk a little bit about defining frailty, and I hope not to get or spark too many debates about how to measure frailty, because I think most of us would agree at this point that we should just measure frailty, use objective tools, and be clear on how we're defining it. But the way I've conceptualized this for you today is based on three large constructs of frailty: the sarcopenia phenotype, the intrinsic capacity construct, and the deficit accumulation construct. And in essence, these three constructs really respect the same basic mathematical formula, which is that frailty is the sum of impairments, where impairments are defined as issues related to aging and associated with adverse health outcomes. The difference being on the left, we're considering fewer impairments, or a more narrow scope of impairments, such as skeletal muscle mass, quality, and function. And on the right, we're considering a much wider assortment of impairments. If we want to take the math a little bit further, we can think of the resilience, or basically we can say the inverse of resilience, as what happens when frailty and a stress are combined. And finally, we can think of disability as what happens when frailty and the environment is combined or is considered together. So we can have patients that are quite frail, but in a very well-surrounded and adapted environment, who do not develop disability, and vice versa. We can have patients who are not too frail, but in an isolated environment, in a non-adapted environment, and they do develop disability earlier on. So I think this is helpful, at least for me, maybe for others, to conceptualize the different constructs of frailty on a big picture level. We started in cardiology with gait speed as a simple screening test for frailty, or geriatric vital sign. And this was, again, thanks to the inspiration of Dr. Duque, and led me to conduct or participate in two studies that are now widely cited. One was in the context of transcatheter aortic valve replacement, where we found that patients who walked slower than 6 or ideally 10 seconds on 5-meter course were more likely to suffer mortality after the procedure. And in a large cohort of cardiac surgery patients now, the same was observed here, with a cutoff of 6 seconds or more being predictive of mortality after a cardiac surgery procedure. In the vein of using simple metrics to predict or screen for frailty, we also recently, with another student of mine, Rosie Funtodos, conducted a similar study looking at grip strength as a single marker to screen for frailty. And we did find that, as others have found, that grip strength is a very powerful predictor of not only 1 year and 30-day mortality, but also prolonged length of hospital stay, a need for discharge to healthcare facilities after a cardiac procedure, with an odds ratio of anywhere from 2 to 3 after we adjusted in this multivariable model. Interestingly, though, frailty as hand grip strength as a screening tool did not really pan out, because a lot of patients that were frail did not necessarily have a weak hand grip strength, and vice versa. So ultimately, we concluded that grip strength is a good informative measure of frailty. However, it's not all-encompassing, and a normal value for grip strength doesn't mean that we shouldn't look further at the patient's other domains of frailty. For those that are interested in the finer points, such as cutoffs, we did compare the FNIH, the European Working Group, freed and indexed cutoffs for hand grip strength. And we landed on the 2616 from FNIH as the most predictive. Here we can see the AUC slightly better when we use this cutoff to define weak hand grip strength than some of the other definitions, very slightly so. We could say that all the other definitions are also very good. But from there, we've kind of retained the 2616 as what we use in our practice. I mentioned that there's more than gait speed and grip strength, and again, that's no surprise to the audience of this Zoom, but we have gone through the exercise of demonstrating the prognostic value of other domains of frailty other than the physical domains that I just alluded to. So we've looked at habitual physical activity in older adults undergoing cardiac procedures, and first finding was that it's quite low. So older adults tend to do very little physical activity once they have advanced forms of cardiac disease, and it's clearly predictive of a worse outcome after the procedure, even if the procedure is highly successful. We've done the same with malnutrition. Here, using a brief instrument to screen for malnutrition, we looked at the interplay between physical frailty as measured by the SPPB and malnutrition. And what we could see here in the bottom bar is that the combination of malnutrition and low SPPB scores resulted in a much higher rate of mortality at 1 year after, again, a cardiac procedure, here at 41%. If we contrast that to patients who are well nourished and have normal SPPB scores, the risk is only 40%. So, you know, a tenfold increase in mortality rate based on the combination of physical frailty and malnutrition. So something certainly to pay attention to and potentially treatable as well. Moving towards some of the non-physical elements, we found that here with a student of ours, Laura Drudy, who's now a vascular surgeon, we found that depression was an important determinant of post-procedural mortality. And similarly, anxiety was also an important determinant of post-procedural mortality and major morbidity. And this was kind of equated to the patient who is worried and anxious about having a bad outcome, often being correct and having that intuition for some reason that is valid and that reflects certainly some underlying biology in that patient. If we move past these domains, we could look at what happens when someone is frail and, again, potentially in a non-ideal environment and develops disability. This is really a trio of elements that we like to disentangle, at least in our practice, meaning frailty, disability, and comorbidity, clearly interrelated, but helps us to be a little more coherent when we measure them and talk about them as elements on their own. And we can see that when we do consider them, when we've assessed them on their own and then we put them together in a synthesized way, we can appreciate that the gradation of risk here in this study really increases, especially if we look at levels 5, 6, and 7 as patients develop mild, moderate, or severe disabilities in basic activities of daily living. These are patients that are really at the furthest stages, and we find this quite. We use this quite importantly in our decision making, in our assessment of patients when they have significant basic ADL disabilities. As I mentioned, when one of the first multi-center studies that I led looking at different frailty elements was started in 2012 and funded by the Canadian Institutes of Health Research. And the goal there was really to develop a simple tool for cardiovascular practitioners, be it surgeons, doctors, nurses, allied healthcare professionals, to measure quickly at the bedside, minimizing questionnaire elements, minimizing lengthy checklists, and just giving something practical that would give a good impression of frailty and hopefully an actionable one. So we looked at many different domains. We measured these across 14 hospitals in 3 countries, just over 1,100 patients recruited. And what we found as far as the most parsimonious but yet predictive scale was as shown here. We called it the Essential Frailty Toolset. And it consisted of timed chair rises for 5 chair rises, more or less than 15 seconds or unable. It consisted of a cognitive assessment, initially with a mini mental status exam, less than 24, defining cognitive impairment, subsequently with a mini cog performing similarly well. And then 2 simple biomarkers, so hemoglobin and serum albumin, to reflect chronic inflammation and to a certain extent nutritional status. With this, we were able to predict quite well who would survive or not survive the procedure. And more importantly, we were able to determine who may develop incident disability and poor quality of life after the procedure. So focusing not just on the hard outcome of survival, but also on the outcome that is patient-centered. We had some funding from the Canadian Frailty Network to develop an app to help the clinician do this at the bedside. I'm happy to always see the downloads on this from all across the world. It's something that, at least in the cardiovascular community, has become often used to help assess patients and guide decision-making. And I certainly think it's, addressing a few domains as done here is preferable to just the one-stop shop of something like gait speed or grip strength. I think here we have a little bit more of the domains represented. And in the app, we can go steps further and assess things like nutrition, mood, disability, and so forth. So we have the option to go further if we have the clinical suspicion or the time or the desire to go further in that assessment. And I'll also say that I often perform this assessment in my outpatient clinic. So as the patient sits down in the chair in front of me, I perform the mini cog. I ask them to recall the 3 words, and I then have them do the 5 chair rises, which I will time. I ask them to remember the 3 words, and then I check their hemoglobin and albumin, and I'm essentially done with that quick screen. So it takes just about 2 minutes, and it's for the most part objective on their current status. So here we see the readout of that app. What happens if we do that for our 3 gentlemen that we started with? Our gentleman on the left has a 1-year predicted risk of mortality based on his EFT score of 1 out of 5 of 7.5%. Our gentleman in the middle scores a 5 out of 5 on the EFT and has a 1-year predicted risk of mortality of 57.3%. And our gentleman on the far right is intermediate with a score of 3 out of 5 and a 22.1% predicted risk of 1-year mortality. So what I think is important to note here is that when we just use the typical cardiac risk score, all 3 patients had a nearly identical predicted risk of bad outcome. But when we use a geriatric-oriented instrument with elements of frailty incorporated, we now tease apart the 3 patients in terms of their true prognosis, and that's quite helpful for patient-informed decision-making and future care. What we also have spent quite a bit of time doing is looking underneath the hood of the car, so to speak, which is not accepting the eyeball assessment from the outside of the patient, but rather trying to use imaging to get an idea of the patient's body composition and internal frailty, if you will. And we've mainly done this to date with CT imaging, but we've used other modalities. So this is a tool called Core Slicer, which is available online, an open source model, which was developed by myself and a student at the time, Louis Mully, who's now an ICU doctor. And what we do here is we leverage a CT scan, which would have been done for clinical indications. Here for procedural planning, we identify a landmark axial level. And from here, the initial design was providing tools to help the user segment or color in the muscles and the fat in a rapid way. Here we're doing the left and right psoas muscles. And on the right, you can see the readout of that. So again, let's come back to our 3 patients. You'll remember that the 3 patients had, the 2 patients on the left had the same BMI and the one on the right was obese. So our gentleman on the far left has a body composition as shown there with a psoas muscle area of 27 square centimeters. That is almost double the patient in the middle, who has a psoas muscle area of 16.1 centimeters squared. And it's also more than, surprisingly, the obese patient at 18.5 centimeters squared. And one common misperception or misconception is that obese patients or larger patients are robust. And what we see time and time again is that the obese or bigger patients tend to be even more frail than the thinner patients. So kind of counterintuitive, and again, speaks to the importance of measuring things objectively rather than going by an eyeball assessment. We've used this software platform in many different cohorts. This was the first cohort we looked at, which was TAVR, where the dotted line defines patients with a low psoas muscle area and also the worst survival after a TAVR procedure. We've used it in patients undergoing cardiac surgery, where we showed that as the psoas muscle got smaller, moving from right to left on the x-axis, the length of stay after surgery got longer or higher on the y-axis. Both of these projects were led by students at the time, and so were the two papers on this slide. One on the left in vascular surgery, again, low psoas muscle area with assessed pre-vascular surgery portended worse survival. And even here in cardiac surgery, cardiac transplantation, a population that is typically less advanced stage than some of the others that I've shown, assessing the psoas muscle area was also quite telling of survival after this procedure. Again, with the going back to the title of the talk, we're talking about all things that are outside of the heart and outside of the usual lens of the cardiovascular practitioner. And these are the things that are driving prognosis after an apparently successful, or I should say technically successful, cardiac procedure. As you know, there's many different ways to assess body composition and muscle mass, some with questionnaires, others with imaging modalities or other. We've kind of played with all of these modalities. Here's one of our more recent papers led by a student of mine, Ayushi Joshi, on DEXA-based sarcopenia assessment in patients undergoing cardiac surgery. And similar to what we found with CT-based sarcopenia assessment, here again, the sarcopenic patients do quite a bit worse after cardiac surgery than their non-sarcopenic counterparts. Something that I think speaks to some of the work that Dr. Gustavo Duque has led and continues to lead on osteosarcopenia. This is something that we looked at more recently with a visiting geriatrician fellow from Spain, Pablo Sola Suarez, where we took the opportunity to look at those CT scans of TAVR patients to quantify not only their muscle mass, but also their bone density on the CT scan. And we appreciated that the patients who had both osteopenia and sarcopenia, so-called osteosarcopenia, were more often than other subgroups the ones with the lowest short physical performance battery scores here, so the most frail. And importantly, we appreciated that when, again, this phenotype of osteosarcopenia was present, the survival after the aortic valve procedure was quite a bit lower than if it was just the bone density or the muscle mass that was reduced. And this is something certainly that we're very interested to explore more. It seems like the combination of osteopenia and sarcopenia really identifies the truly frail body composition, and it may explain or may help to kind of rectify the issue of muscle quality. And the way I've kind of thought about this is when we have small muscle mass or low muscle mass, we're always doubtful as to whether this is a low muscle mass of poor quality, which is truly sarcopenic, or a low muscle mass of high quality, which should not be sarcopenic and should not have a reduction in muscle strength or function. However, if we're just looking at a CT scan, we don't have great measures of muscle function or performance. We could derive some measures of muscle quality, although perhaps they're not too robust if we're just focusing on Hounsfield units. So perhaps, as we've hypothesized, the presence of osteopenia in that context will kind of shift us towards thinking that this is probably a low muscle mass of low quality or of sarcopenic etiology, rather than someone who has good bone density, who may just have low muscle mass of high quality. So just a thought, no proof yet to that hypothesis, but certainly I think it's something that is important prognostically and has also therapeutic implications. I alluded to the obese sarcopenic patient, our gentleman on the far right, and this is something that we see time and time again, where obesity and sarcopenia are present together. It's been well defined in the geriatric literature as sarcopenic obesity. And in a recent systematic review and meta-analysis that we authored with our student, Yitzhak Ahisar, we did find that this even goes back to the genetic underpinnings of frailty, in the sense that the genes associated with physical frailty and sarcopenia overlap to a large extent with those of metabolic syndrome and also with those of cardiovascular disease, which again may explain why we see this trio so often in the sense of, sarcopenic obesity with cardiovascular disease. So we found a number of SNPs that were common to the three pathophysiologies. Now that we have a good idea of how to assess frailty and the important elements in assessing frailty, I think it's noteworthy to mention a few challenges. One challenge would be to assess frailty upstream. So ideally in primary care when patients are at a stable baseline, and also when there's a chance to intervene, prevent primary prevention of poor outcomes. This is something that is not yet commonplace, at least in my neck of the woods. That's certainly something quite important. At the other end of the spectrum, assessing frailty in the emergency room and in the ICU is a time that many of us are desperate to have this information to make good decisions for our patients that will maximize the chances of a good outcome and minimize futile and costly procedures. Continues to be a challenge, but I think with some of the tools, whether imaging biomarkers or blood-based biomarkers, we're making some progress here in terms of assessing frailty in the emergency room and in the intensive care unit. Of course, there's also tools like the clinical frailty scale that we can ascertain with family members retrospectively and get an idea from that. And finally, assessing frailty automatically. For me, that is a priority, to be able to automate this so that my colleagues don't have to worry about calling me or my team to perform a frailty assessment. And if geriatrics is not available for every patient, which they're not, there could be some heads up or warning signs of frailty from some automatic tools. And this is, again, going back to the imaging. And I'll acknowledge another student of mine, Dingyi Zhang, for his help with this pipeline, and also Zara Vajihi, where we're now basically inputting CT images into deep learning models and having the full quantification of body composition and muscle mass assessed in an automated way. And we've shown with this that we can, again, predict who's going to have that outcome after cardiac procedure. So I think doing it in this way and measuring as much as possible automatically with the least manual work is going to be one of the keys to success to get frailty into the mainstream. Just a few little funny images that I came across here showing that, we're talking about high technology in older adults, and older adults do have the capability to integrate high technology, although usually in their own way, and maybe not in the same way that we would do it. This is a good one of an older adult who sent a selfie, printed a selfie and sent it by snail mail. Another good one of an older adult who took a selfie by taking a picture in the mirror. So, I think we're seeing more and more technology in this demographic, and it may not be easy to penetrate, but it, I think there's hope to get there in one way or another. So shifting gears a little bit away from procedures and cardiac surgeries, I should say, even in the outpatient community dwelling setting of cardiac patients, or here specifically heart failure patients, we see a lot of frail patients. This was one meta-analysis that we conducted where anywhere from 20 to 50% of older adults with heart failure were found to be frail by objective tools. And it was an important determinant of prognosis. And it's not surprising in the sense because we know that the prognosis of heart failure patients is often driven to a large extent by non-cardiac factors. So here's a study on the causes of death in patients with heart failure. And you can see, especially in the preserved ejection fraction group on the left, half of the deaths in these heart failure patients were non-cardiac in etiology, and more than a third in the heart failure with reduced ejection fraction. So again, it's not surprising that frailty matters side by side with comorbidity. And we've looked, and others have looked at this as well, in terms of the prognostic value of frailty in heart failure patients, important driver of mortality. Also, important driver of poor self-care behaviors. This was Ayushi Joshi's abstract on this, where patients who were frail and recruited in the heart failure clinic demonstrated much poorer ability to do the basic self-care behaviors like check their weight, eat the recommended foods, and monitor themselves for signs and symptoms of heart failure and seek care when appropriate. So one of the benefits of addressing frailty may be to improve the patient's self-care abilities, and a little more on that coming up soon. We know certainly that frailty and heart failure leads to more hospitalizations. This was one study where we showed that according to the SPPB, patients in the lowest SPPB group spent the most time in hospital in general than their non-frail counterparts. And importantly, we know that if we can elicit frailty at the time of a hospital discharge from heart failure, this is a worrisome sign for incident disability and functional decline. So here, patients in the lowest SPPB group at the time of heart failure discharge had more than a 50% incidence of developing new disabilities 6 months post hospital discharge. So something, again, concerning and to pay attention to. A question that comes up a lot in the heart failure setting is, should we put devices and ventricular assist machines in our frail patients, or is that not a good idea? And what we know in this context is that frailty is associated with poor outcomes, but we don't necessarily know if it is associated with prohibitive outcomes. Certainly the short-term risks of many of these procedures have now become quite reasonable. And what we're concerned about is not necessarily a patient not surviving the procedure, but rather a patient not recovering from the procedure or developing so much functional decline that they have competing issues and pass from those competing issues. So again, when we're asked, often cases I think many of you would have experienced as frailty enthusiasts, we're often asked, is this patient too frail for surgery? Is this patient too frail for this treatment? We're asked, in a sense, for a go, no-go decision or a go, no-go opinion. And that's really, in my opinion, not what frailty is meant for and not what frailty is good at addressing. I think when that question comes to me, what I do is I try to reframe it towards a question of futility, not of frailty. And the markers of futility are different than simply saying a patient is frail or not frail. And this is an algorithm or a mnemonic that I developed and that was published in the recent Canadian TAVR guidelines, and it's one that I use quite often when reviewing cases with trainees, even in the emergency room, I think it's pertinent to think of this. And basically, it reflects factors that are likely to indicate futility, especially if multiple of these are present. So advanced dementia, bedbound or non-mobile status, cachexia or severe sarcopenia, disability for all or most basic ADLs, and end-stage renal, liver, lung, or one could add neoplastic disease as well. So this, again, I think is something to think about before even thinking about, is this patient frail or not frail? Because this is, again, the extreme manifestation of frailty. Something that I recommend to do even before thinking about futility or frailty is just to talk to the patient. And this often is will save a lot of time before getting into deeper assessments, because sometimes patients, according to their preferences and values, will be very clear in stating that they would not want to go down an invasive pathway. And again, this trumps all of the different biomarkers and parameters that we can potentially measure. So something to really prioritize and to discuss with the patient and their loved ones. Where I think that frailty is much more relevant, I mentioned I don't think it's relevant as a go, no go factor. Where I think it's much more relevant is on how to move forward, and whether we decide to do a procedure or not to do a procedure. I think we should, and the time has come to really think about treating the frailty in parallel with treating the heart. And in order to do that, you have to measure the frailty. So I think that's one of the foremost benefits of measuring frailty in clinical practice, is being able to identify deficits that are quote unquote defrailable or treatable, to lead patients towards more favorable outcomes, regardless of what the cardiac treatment will be. We focus a lot on exercise, nutrition, and comprehensive geriatric assessment, because that's where the bulk of the literature has been to date. This is I guess now a more dated systematic review that we conducted, but it clearly showed that the top three were exercise, nutrition, and exercise plus nutrition, followed by a smaller amount of pharmaceutical agents and multidimensional programs for treating frailty. The gold standard still remains, in terms of the assessment and treatment, the comprehensive geriatric assessment, where the key elements of frailty and geriatric syndromes will be assessed, and a treatment plan will be put in place for the patient longitudinally. This really does a fantastic job, and if we could have a CGA for all our cardiac patients who were older, it would be fantastic. We know that the reality in terms of resource availability is not as such. So we've now kind of tried to develop tools or strategies to make the CGA streamlined and more accessible to cardiac patients. This is a trial that will be starting shortly. It's been funded by the CIHR. It's called the Geriatric Intervention for Frail Heart Failure Patients. And the concept is straightforward. It is to identify frailty in older adults hospitalized for heart failure, and when they're going to be discharged, to randomize them to usual care or usual care plus assessment by a geriatrician for a CGA within 2 weeks. And our conceptual model is that this CGA may identify one of many geriatric impairments. It should then put in place an intervention or interventions to help address those geriatric impairments. And what we hope this will translate to is better self-care capabilities for our patients to, as I mentioned, weigh themselves, check themselves, take their medications as directed, eat healthier, exercise, go to their follow-ups, get vaccinated, etc. And we think that if this happens, it should lead to improved survival, reduced admissions, and better quality of life. So this is one model for delivering the CGA in a targeted way with well-defined endpoints. What I often call the antidote for frailty, or the best available antidote for frailty, would have to be cardiac rehab. And I think that in cardiac rehab, we know that there's a lot more than just treadmills and exercise. It's really a multidisciplinary approach to assess not only physical domains, but also cognitive domains, mood, self-efficacy, and risk factor control. And I think that if you line it up with the impairments of frailty, it lines up very well. And in my experience, patients who can attend cardiac rehab, whether center-based or home-based, this is where we tend to see the best gains in terms of frailty, especially after a procedure or a long hospitalization. I mentioned the home-based approach, and one of the things we tried earlier on to make the home-based exercise more feasible, more accessible, and just more easy for patients who may not have access to cardiac rehab was to use accelerometers to get patients walking more after a heart failure hospitalization. And we know that the more patients walk, the more they do better, their fitness improves, their outcomes improve. This study here suggested a target of 7,500 steps per day as a kind of an optimal target for older adults. When we actually measure this and see what older adults are walking, the average is concerningly closer to 2,500 steps per day, at least in the cardiac context. And so we have a lot of work to do here. And what we found with this trial was that just giving patients the accelerometer and sending them home was insufficient to improve their frailty, in part because they needed a little bit more tailoring and touch as opposed to just the tech. And I think this, again, speaks to that, where the older adults can use technology, but they're not necessarily going to use it in the way that is written in the way that we're used to. And so they will, find workarounds. And if we want technology to be used by older adults, as was done here, we have to take the effort to explain it and to make it geriatric friendly, to achieve some feasibility there. And that's something that we've learned from this Get Going trial, and we've tried to implement in the Perform TAVR trial, which was mentioned before, where not only are we giving patients exercise programs and protein supplements after a cardiac procedure and also shortly before, but we're actually sending a therapist into the patient's home twice a week to coach the patients, to ensure their adherence, and to motivate them and explain to them what needs to be done, and importantly, to adapt it to their capabilities and to their literacy for these elements. And we do that for 3 months after the procedure, and we're looking for a durable improvement in quality of life and physical functioning after that. So results of this are about 1 year away. We know from the literature that, again, rehab and exercise should be started early to have good effects. This is a trial that I like a lot from a group in Spain, where simple exercises on the hospital ward really had a meaningful impact in short physical performance battery. And a colleague of mine, Michael Goldfarb, has looked at this even in the cardiac ICU, looking at starting mobilization and activity for frail older adults in the cardiac ICU. And while frail older adults have slightly lower level of functioning, they do benefit from these interventions. And so they should be considered eligible for such protocols. If we don't do this, and if we kind of stay only focused on the heart and the cardiac treatment, and our patient stays in bed, we know what happens. They get deconditioned, they lose muscle. 10 days in bed equates to 1.5 kilos of muscle loss. And for those who are not sure what that represents, that steak you see in the top right corner is a 1.5 kilo steak. So you can imagine if that muscle mass on an already depleted patient is lost, we're really in big trouble. And again, I like this quote of why is it acceptable if the physio cannot come every day, but not acceptable if antibiotics are not given daily. And I know this is a resource issue. We absolutely need more physiotherapists in the hospital. Not enough are provided. Just one example here of a patient, slide courtesy of Dr. Maud Roberge, who's one of our geriatric cardiology fellows presently. What happens in a patient who gets admitted and is sick and stays in bed? Here, there was a CT done for an abdominal issue, and the CT was repeated for the abdominal issue later on, but we took the chance to measure the muscle and body composition pre and post, and we can see that there was a 18% reduction in the psoas muscle area after that 2.5, 3 week period of hospitalization, something we observe time and time again. One of the main reasons for this is not only the immobility that we discussed, but also the protein deficits. This is showing that patients who have cardiac surgery are well below their optimal protein intake in terms of, hopefully 1.5 to 2 grams per kilo per day when they're catabolic. They're more in the 0.6 to 0.8 range in the post-op phase. Many barriers to nutrition, many reasons for this, but clearly a major problem. And a problem that we can address. And we even have evidence from major RCTs here from the NOURISH trial that addressing nutrition with oral nutritional supplements in the hospital could have important effects even on improving mortality for such patients. And lastly, if we're not going to give nutritional supplements, at least let's not make our patients NPO for too long. And so this is one trial in cardiology looking at should we make patients NPO or not before a cardiac cath. And basically the take-home message is that the NPO is kind of useless in this setting and does not result in any fewer adverse events like aspiration or other. If anything, being NPO causes more hypotension, and we know it also causes more muscle loss. So a push to not assume NPO is the right thing to do before a procedure. We're heading in kind of the opposite direction with the recent literature. So in conclusion, I think we've learned that it's very important to start by identifying red flags for futility. The ABCDE mnemonic can be helpful. Just as important, if not more, to speak to the patient, get their preferences and values. Once we've done that, we can start to look at frailty with things like the EFT or other tools. And rather than just focusing on the prognostic meaning of that, let's try to treat it. And let's try to get physiotherapy involved, nutrition involved, prevent delirium and so forth. This is the kind of quick screener that we do with the Essential Frailty toolset, and 2 questions for malnutrition, depression, and disability to screen for those elements. Our patient on the far left ended up getting the cardiac procedure and is doing fantastic in gardening 2 years later. I'd like to end with this slide, which really I think encompasses all of what we've talked about today, which is being more important to know what sort of a patient has a disease than what sort of a disease a patient has. Shameless plug for our geriatric cardiology fellowship program. Would be happy to discuss further with anyone who may be interested. And I thank you very much for your attention today. Welcome any questions.
Thank you very much, John. That was a fantastic presentation. And thank you for your kind words about our interactions in the past. And I think that something that I really admire of what you have been doing is the translational impact that you have in your research, which is important to everyone, especially in the field of frailty. So John, we have a few questions and we don't have a lot of time, but I will try to go over most of them. So Natasha asks how the AFT is being used in clinical practice. It's like something that is brought up in shared decision-making or cut off to stay a patient or determine if a patient is too frail to undergo any procedures.
Yeah, so more the first, it's definitely used as a tool to first feed back to the treating team what the level of frailty is and what that means for the patient's prognosis. That works its way into the informed decision-making process for both the team and the patient. We try to discourage clinicians from using it as a go, no-go decision maker, because again, what they're really looking for there is markers of futility, and that's not what frailty is. Frailty is a syndrome of fragility and high risk, and it's potentially improvable. So it does not equate futility. So we try to discourage people from viewing frailty itself as a go, no go.
Thank you. We have also a question from Ivan Abrahamian, a good friend, who says, "Hi, Jonathan. Thanks for your excellent lecture. Just want to thank you, especially the course licensors, but he has a question about it. Very nice contribution to clinical practice. Did you validate it with DEXA or MRI?"
So we validated it. We validated Core Slicer against other commercially available tools to measure muscle mass on CT images. So it was we've published a CT versus CT validation where all we changed was the tool. So comparing Core Slicer against other tools. And those other tools have been validated against MRI and DEXA. Although in cardiac patients, DEXA, I would say, does not correlate perfectly at all with imaging modalities like CT and MRI, because we get fooled by the edema. Edema often counts or inflates the lean mass measured. And so I think ideally the comparison would be towards MRI, and that has been done by previous groups.
Thank you. We have another question from Benzel asking about frailty and heart failure self-management. Asking what is the lag time to benefit from different parts of self-management, and do these frail individuals with heart failure actually live long enough for it to make sense?
Yeah, I think it's a good point. The certain interventions will have a more short-term benefit. So you can imagine the older adult who has an undiagnosed vision impairment or hearing impairment, which is detected in the CGA and leads to the patient getting the right sensory aids. That patient is now able to hear their doctor. That patient is now able to see their scale. And that may have very short-term benefits for the patient. With things like exercise, the benefits tend to be anywhere from the short to medium term. But if we can get patients doing more regular exercises as part of their self-care, they tend in the short term to feel better, and in the medium term have, again, better outcomes. I would say the same for nutrition. So I think collectively, there are some elements that are more short-term, others more medium-term, and then others more in the long-term. But gone are the days that heart failure patients are only living a few months or a year. Now that, heart failure patients, even at older ages, are living on average many years. So we certainly have time to get them less frail and taking better care of their disease.
I will use my right as chair of this session to ask you a question, John, and this has to be biological. So in the correction that you make of the frailty phenotype after the intervention, talking about the pathophysiology of frailty, do you think the improvement in the frailty phenotype is due to a specific biological mechanism of frailty, or just because of the cardiovascular recovery post-procedure?
I think a lot of it has to do with working on muscle mass and strength in terms of the pathophysiology. I think that with cardiovascular diseases being highly inflammatory, and with surgical stress being highly catabolic, the impact on patients' muscle mass and strength is often profound after a procedure. So I think that the nutritional support with high protein supplements and the exercise, both resistance and aerobic, plays a part to get some of that back or build it up before the procedure so that the baseline is not as low. That's where my my intuition is as far as the mechanism of all this. But certainly the other domains factor in too, to helping the social and environmental support of the patient as well, I think is major. So I think it's a bit of everything, but I think the sarcopenia is one that's important and very tangible and direct.
Excellent, thank you. Just the final question, because of the interest of time. This question is from Kafir from Turkey. Thanks for the wonderful presentation. He's asking, or she's asking, about the impact of delirium on mortality risk in this patient undergoing cardiac surgery. So how delirium fits within this model?
Yeah, delirium is one of the things that we look at closely as an outcome. Frail patients are more likely to develop delirium, especially when they have cognitive frailty. So we do look at that, and one of our current trials and interventions, in addition to assessing physical frailty with exercise and nutrition, we use cognitive reorientation and stimulation exercises in those patients who are frail to try to prevent delirium to the best extent possible. So I think it definitely is in the same bucket of things that can go wrong and that can be improved by interventions against frailty. And I'll leave it at that. I'll also just say hi. I noticed Selina Arif is on the call, and she's our incoming geriatric cardiology fellow for next year. So hi to Selina.
Okay, so for the interest of time, I think we have to close the session for today, but we still have a few questions. Please feel free to write those questions to John directly. His email address is on that slide, and his Twitter and all the other contact info. So on behalf of, again, of the organizing committee, I would like to thank John for taking the time to give us this fantastic presentation. And a reminder for everyone to join us at the next seminar on December 8th with Melissa Andrew. And remember that these seminars are being recorded and are going to be available online. So you can, we will send you around the links to those seminar, the recordings, and also the links to register to the next seminar. With this, I would like to thank everyone for your attendance and your attention, and looking forward to the next seminar. Have a nice rest of the whatever afternoon, morning, or day today.
Thank you.
Thank you.
Thank you.